Okay. So again, I told you there's going to be a lot of causes and treatments and diagnostic tests we're going to do for sepsis to figure out what it is, right? So we're doing a whole rainbow of examinations to figure out what is happening, right? We can look at the symptoms, right? We're looking for what's hot, right? So what's hot on the patient, right? Is the knee hot? Oh, that might be a septic arthritis. They might have some sepsis brewing in that knee, right? You got a hot coccyx, right? So that might be might have something forming underneath, right? Obviously, turn them over and the coccyx is broken down with a stage 4. That might be the source as well, right? So we're looking for these sources of infection, right? Of course, we can use our stethoscope, listen to the lungs, see if they have good lung sounds, right? They might be diminished on the right side, not the left side. They could have an effusion on the right side, or they have bronchi bilaterally, right? That could be a really severe sputum production from a pneumonia of some sort, right? But starting from the beginning, we're going to have systemic inflammation symptoms or SIR symptoms. So that's your what? Your 4 things. Your respiratory rate and what else? Your white blood cells and your temperature and your heart rate, right? So those 4 are elevated. Only 2 of them can be low for SIRS by definition, right? So you can have an elevated temperature or a low temperature. It depends on whether you can make a temperature response. And the other one that can be low or high is which one? WBCs. So WBCs are low. It could be a response to sepsis. It could be an exhaustion of your white blood cells, or you don't have enough white blood cells to give, like in a neutropenic patient, right? So we got a surge response, right? We got a fever, SNS symptoms. SNS symptoms are your heart rate and tachycardia, right? Or sorry, your heart rate and respiratory rate. And then CBC will tell you about your white blood cell count, right? You can't just hold your hand over someone's forehead. You got 18.2, right? So that's not going to happen. So you got to do a CBC, and that will tell you that what their white count is. And you can look at the differential of the white count to tell you that they have a bacterial infection or a fungal infection or a viral infection, right? Or even an anaphylactic reaction, and that's why their white count's elevated and why they're hypotensive. It wasn't sepsis all along. It was anaphylaxis, right? And then are they altered? So being altered is, especially your elderly patients, as a sign of lack of function of the brain because of all these inflammatory mediators are not only shutting down the kidneys and the heart and lungs, but they can also shut down the brain, so it doesn't function as well as it should, right? So we're assessing perfusion. How much perfusion are the organs getting, right? So lactate is where we're headed at. That's an overall assessment of how much perfusion the organs are getting. All right, lactate greater than 2, you're suspicious. Lactate greater than 4, you close the book, you know for sure they're hypoperfused for some reason. So you got to figure like what's hypoperfused. Is it like they have like a dead leg? That could be the reason. They could have a dead bowel, or they could have lack of flow, just the tissues in general, because of like cardiogenic shock. The heart's not pumping blood to the periphery, so that's why the lactate everywhere is kind of going up. Okay. And then what else? If you start getting lactate greater than 4, that's going to start raising my my anion gap. So we'll talk about anion gap a little more in renal. Talk about high anion gap metabolic acidosis. We're going to develop a metabolic acidosis, and that's defined as what? How do you know someone has metabolic acidosis and not respiratory acidosis? So the bicarb is a good clue, right? So the bicarb might compensate in 18 hours or so, but someone who's developing lactic acid this quick, their bicarb is going to go which direction? Down. All right, so bicarb is going down because it's neutralizing all the lactic acid that's being formed, right? So the bicarb level is going down, right? And we can assess that on a chemistry if we can't afford an ABG. But also an ABG, if we do an ABG, we can get a pH, right? The pH will be what? Be low, right? All right, so poor perfusion is a red flag. They got cool, pale skin. They got mottling occurring on their knees, especially, right? The blood pressure starts dipping below 90, or that 40-point thing, right? If you see someone with a history of hypertension and they come into you with a systolic of like 100, that's something that you're going to pump the brakes and say, wait, did you take your BP meds? No. Well, that's even more concerning because BP meds, you should keep it around 120 to 130. But if they didn't take them and the blood pressure is on the low side and they have a history of hypertension and they're on BP meds at home, what's going on? Why are they getting lower blood pressures, right? So 40-point drop from baseline. And then we're going to do a full physical assessment. We're looking for, a septic shock can come from anywhere. So head to toe, you can look for, it could be a meningitis, right? You can look for nuchal rigidity and Kernig's and Brudzinski signs, right? You can try to figure out, do they have a meningeal symptoms, right? And a CT maybe help for here, but really it's going to tell you if you have a subarachnoid hemorrhage, if you need to, if it's safe to do an LP. but LP is on the plate, as if you really are suspicious of that. But usually LPs we kind of do last because it's pretty invasive, right? If everything else is ruled out, for a source of infection, then we'll kind of go to LP. So it's not exactly head to toe. But we can go down to neck and lungs. We can think of like an upper respiratory infection or definitely a lower respiratory infection like a pneumonia of some sorts, right? We're looking to see if they have infiltrates on X-ray, see if they have lung sounds that are poor. And then going down, you can see if they have pyelonephritis. How do you know someone has pyelonephritis? They have inflammation of their kidneys because of pus, because what are they going to feel with that inflammation? Costovertebral angle tenderness, right? CVA tenderness. So they have that tenderness on their lower ribs, where their ribs and vertebra meet, right? And that's going to be a reason for their sepsis. So again, you asked about UTI symptoms. Hey, do you have any wounds? Right? Oh yeah, I got this huge wound on my heel, right? The one that's only covered with the sock, right? So then you can realize maybe that's the source of their infection, like an osteomyelitis, worst case scenario, right? You can ask them, do they have, if they've been to, the symptoms in one specific spot, like do they have like endocarditis? How do you know someone has endocarditis? What are the symptoms? Well, they're going to have fever, tachycardia, they're going to have a lactate elevation. But no, what's specific to endocarditis? Murmur, there you go, right? They got endocarditis, that means the valve has been infiltrated with bacteria. I got a murmur developing, right? Well, it's not a murmur because of cardiogenic shock, right? We're kind of looking, yes, you could do an echo to make sure that it's not like a cardiogenic situation, but on echo, what are you going to see? If you heard a murmur, you're going to probably see some vegetation on that valve, right? And of course, blood cultures are going to help us identify what is growing there. Okay, they have recent hardware, they have recent lines or ports, right? They have I just got my PICC line removed 1 week ago, and now I'm feeling feverish and like I got palpitations, and I'm breathing really fast, I'm diaphoretic, and then you assess them, you assess for a murmur. It's like, well, shoot, this might be endocarditis from your line might have got infected, right? So we're looking for, what's kind of the history that would explain why they're septic. And when you discuss sepsis, again, this encapsulates a lot of the disease processes you learned in nursing school. So you're all kind of putting it all together. That's why it's one of the more complicated diagnoses, right? Because there's a lot of things going on, a lot of moving parts, right? You have to know about meningitis and endocarditis and UTI and pyelonephritis. You have to put them all together, right? And then signs of organ damage. So we know we're no longer in sepsis. We're in what if we have organ damage? MODS, maybe, if you have 2 or more. But if you just have 1 damaged, that's a severe sepsis, right? So we have chemistries will tell us about our BU and creatinine. They'll tell us if we have a comprehensive metabolic panel. They'll tell us about our liver function, right, and our T-bili, for instance, to see if that's going up, right? So liver, hematological failure, is our liver shutting down, and are we going to DIC? That could be a reason for a drop in my platelets and a rise in my coags. That could go in the DIC, and that's a sign of multi-organ failure as well. My organ that failed was my hematological system, right? So doing CBCs, coags, and doing a CMP is probably every septic patient, every ICU patient usually gets these done so that we can make sure we don't miss anything, leave every stone not unturned, right? And then what else? Diagnostic tests, we can do cultures. Cultures are going to tell us if what's growing, right? How long does it take to grow? 48 hours at least, right, on a good day, or on a good 2 days. So 48 hours of culture growth. So, but you want to get it and find out what it is, because we're going to start them on the strong stuff, on a lot of strong antibiotics ahead of time, right? So we're going to say, how sick are you, right? And we're figuring out, do you have a community-acquired pneumonia or a hospital-acquired pneumonia? Which one's worse? Hospital-acquired is worse, right? It could be severe bacteria like Pseudomonas or MRSA that are causing that bacteria. And we have to be on the right antibiotics to cover it that are broad spectrum, right? And then what else? If they have a UTI, we got to say, hey, do you have this UTI just because you're out and about, or did you get it because you had a Foley catheter recently? Or do you have repeated UTIs? So there's that receive antibiotics, right? That's a complicated UTI versus a non-complicated UTI. Okay, and then skin and soft tissue infections. So we have antibiotics that are for SSTIs, not sexually transmitted infections that cause UTIs, but skin and soft tissue infections that could be an abscess of some sort or a wound of some sort that we need to give antibiotics for, right? And then we have abdominal infections. If they have abdominal infections, we have to then, figure out, oh, you got a CT that showed that abdominal infection, or you see an obvious like appendiceal abscess where they had a recent appendectomy. That could be a reason why we need to just give antibiotics for that specifically, right? Other things to consider with antibiotics is to consider if they have received it before, the antibiotics before, or if you just don't know, it's unknown. Couldn't figure it out, but you're in the ICU on pressors. I need to give antibiotics, right? And within how many hours did we get antibiotics? 1 hour. That's the goal. Okay. So cultures before antibiotics, obviously, so we can figure out what it is and we can narrow it down. Say you either have MRSA or Pseudomonas. It's very rare to have concomitant bacterial infections. You can have like a viral infection that makes you have a bacterial infection, but you usually don't have like MRSA and Pseudomonas at the same time, cause of pneumonia, for instance. You can have a MRSA UTI and a Pseudomonas pneumonia, right? So that's possible, but usually only one of them made it the way to the bloodstream and caused this widespread sepsis process. Okay, procalcitonin, we'll talk about on the next slide, but procalcitonin only goes up when you have a bacterial infection. So if it's greater than 0.5, boom, you got a bacterial infection, right? Lactate's elevated. Right? It's not cardiogenic shock anymore. It's septic shock, right? It's not hypovolemic shock because lactate's elevated. If your procal is elevated also, you have a bacterial infection of some sort. Enough to cause this, when it's greater than 0.5, that's enough to create a spillage into the bloodstream to cause to tell you that you have bacterial stuff developing, okay? So again, diagnostic tests, chest x-ray, look for lung stuff. Right? Do you have dyspnea? Do you have sputum? Do you have fever? Is it green sputum? Is it yellow sputum? Right? To look for pneumonia. UAs, you're looking at the urinalysis to see if there's leukoesterases or nitrates that are positive. That'll tell you have a UTI guaranteed. The other follow-up to that is look at the white blood cell count of the urine. If it's greater than 12K or so, that tells you that you 100% have a UTI. If the nitrite or leukoesterase is positive, either one, and the urine WC is positive, you got a UTI. Okay, is it causing it? It might be incidental, but if you're doing odds, right, the most common cause of sepsis is pneumonia, right? About 50% of the time, I can't circle good. So 50% of the time, it's pneumonia, right? And now you're looking at the other 15% for each one of the other ones, such as a UTI, right? Urosepsis. CT abdomen it can look for pyelonephritis, but it can definitely look for like a GI process. Do they have some gastroenteritis? Do they have a colitis? Do they have a perforation, right? Do they have a diverticulum that's perforated or a diverticulitis? Do they have an appendicitis, right? Or they can see ulcerative colitis changes a little bit, but endoscopy would be better. By the way, CT abdomen can reveal a lot of good information. Do they have an obstruction of some sort? Because a small bowel obstruction is not a problem. It causes some pain and such, but when it starts causing, the brewing of bacteria, they can then translocate through the mucosa that doesn't work good into the bloodstream. And that can then cause our sepsis process. And then we have usually a gram-negative sepsis that develops from all those gram-negative bacteria in the CT in the abdomen. Do they have diarrhea by history? They have recent antibiotic use that clues you into what kind of bacteria? C. diff, right? And constipation would be like small bowel obstruction. And where's the pain? If it's in the right lower quadrant versus left lower quadrant, can tell you if it's appendicitis versus diverticulitis, right? And the ultrasound of the abdomen. You think a CT would be great, but actually it's not great for gallbladders. The ultrasound is actually better for gallbladder. And you can see if there's stones in the gallbladder itself or in the duct, right? If they have cholelithiasis or choledocholithiasis. And then MRI can be used. You can use it for anything. It'll tell you, but usually we reserve it for, definitely if they have like a bone infection or a wound infection of some sort. That's where you're going to see if they have like osteomyelitis brewing in the soft tissue. And how would you know? They got cellulitis there, redness, drainage, and if it's an open wound for sure. They had that wound for a long time, diabetic patient. These are a higher risk for osteomyelitis, and an MRI should be gotten, right? Like we mentioned, what's hot, right? If they got an inflamed joint, that could be a reason that they have a sepsis, right? They have septic arthritis. There's a bacteria brewing in that sepsis, at that synovial space, and that's causing that will translocate into the bloodstream, right? And then ascites. So ascites we'll talk more about in liver, but one of the complications there is that you have all this volume of fluid in the belly, right? All this volume of fluid. You have a gut over here, all right? And you have all this ascites happening, and now the white blood cell can go from point A into the bloodstream. It can swim around in there, it can procreate, right? It can have a lot of fun in this Lake Havasu of the ascites, right? So it has all this extra area to proliferate and grow, because it's very difficult to deliver white blood cells to places that don't have capillaries, right? And acidic fluid does not have capillaries. So it's translocated from the gut into the acidic fluid, and it causes what's called spontaneous bacterial peritonitis. So you get SBP or peritonitis from a liver failure patient, especially because they're high risk for ascites, right? And they got your peritonitis symptoms. They got diffuse belly pain. They got their guarding, right? They got purulent output if they had a recent PD cath, like we had a stent of PD cath infections, right? So that could be a reason for peritonitis as well. Okay, they got plastic in the patient. Take out the plastic, please, right? They got a ventilator. They got ventilator-associated pneumonia. They got a line. They get collapses. They got a catheter. They get a caudy, right? So we got to take out the plastic out of the patient if we can, right? An echo going to let you know if you have pericarditis or endocarditis, right? Do you have a new murmur? Do you have a new rub? Do you got chest pain that's laying flat versus just sustained, right? If it's chest pain worse when I lay flat, better when I lean forward, you're looking at pericarditis, right? And after everything else, like we mentioned, that's when you start looking at meningitis, right? It's it's like 1% of causes of sepsis, especially septic shock. All right, complications. We're looking for complications of worsening sepsis, right? Lactate keeps going up. The end organ damage, new organs start damaging. Right, the creatinine goes down on other patients. They get DIC. The ABG gets worse and worse and worse. The pH keeps dropping from 720 to 702 to 692, right? So that's a worsening acidosis and a worsening septic patient. In that patient, we really need to find out what the source is and do source control, and maybe even change antibiotics. So maybe the antibiotics we have them on are not strong enough, and instead of using like a handgun, we need to bring like a tank to the fight. Okay. So there are septic shock mimics out there, but usually when your lactate is greater than 4, you can't really say that it's a mimic. But there are other reasons why you would have a temperature elevation and a white count elevation, right? You're on steroids, right? You're gonna have you might be at more risk for infections, but we're looking for are there other reasons for this classic presentation of septic shock? But when the lactate is greater than 4, you're not going to have these symptomologies. Also procal. So procal greater than 0.5 are procalcitonin. This is really what kind of seal the deal. Until you don't have a septic shock mimic, you actually have septic shock. You actually have, or a sepsis mimic. You really do have a bacterial infection of some sort. There are false elevations like end-stage renal disease. You're not getting, your procal might be a 1 instead of 0.5, but your procal is like 8 or 14. That's not because you have end-stage renal disease. You're not getting rid of the excess procalcitonin. That's definitely something's brewing inside. Okay. So there are several things that can insult the body that can cause like sepsis-like picture, but how do we know someone's progressing to sepsis, severe sepsis, and septic shock? We're looking at their renal function. We're looking at their liver function, their hematological function, and if those are worsening or their organs are failing, we can say they're going into severe sepsis and septic shock, right? These other ones rarely go into these situations, right? But if you have thyroid storm, they're definitely going to have elevated respiratory rate and tachycardia. Does that mean you're in septic shock? No, that means you're in hepatotoxicosis, right? So there are other reasons for elevated heart rate and temperature, or elevated heart rate and elevated respiratory rate, as we know. Right? The SNS fires off for many, many reasons, many, many disease processes. Okay, so the first hour. What do we do in the first hour when we have someone who's septic? You get broad spectrum antibiotics, and again, we're asking the questions. Have you had antibiotics in the last 3 months? Have you been to the hospital the last 3 months? Have you had a Foley catheter recently? Right? Do you have any wounds I need to know about? Right? I'm going to find them. And then you have to ask them if they have, then we can look at abdominal processes. So they have a CT that was done that shows an abdominal process of some sort, right? You can do an X-ray. An X-ray shows infiltrates bilaterally or infiltrates on one side. That could be an aspiration pneumonia on the right side, right? So there's antibiotics we give for these things, right? Prior antibiotics, usually we're going to avoid them, right? We don't want resistance to form, so we're going to change it up a little bit this time around, right? MRSA is usually indicated when you have a skin infection or a recent hospitalization because you get exposed to MRSA. Dialysis patients are exposed to MRSA. Homeless are exposed to MRSA. And then Pseudomonas. This is usually a bacteria that grows when in the hospital setting. And if you have a recent UTI or a recent pneumonia, and you're hospitalized for it, you're a high risk for developing Pseudomonas. And if you're coming to ICU, it could be Pseudomonas. Pseudomonas causes severe infections, and if someone's coming to the ICU, usually recovering for Pseudomonas, recovering for MRSA, and recovering for gram-positives, gram-negatives. Yes, Pseudomonas is gram-negative, and yes, MRSA is gram-positive, but certain antibiotics cover certain things. And we'll talk about antibiotics and more about Pseudomonas and MRSA and such. But that's why these patients are on these antibiotics, and they should have that coverage. If your patient's not getting better, it's like, hey, should we maybe have a stronger antibiotic, right? I'm going up in my pressors from 4 to 10 to 12 to 16 mics Levophed, and we just gave a little measly ceftriaxone, right? Ceftriaxone is what they get on MedSurg 3, right? You get for a UTI or for a pneumonia. But if someone's in the ICU on a ventilator, ceftriaxone is like, providing baby aspirin to someone, right? It's not going to do a lot. So we have to then bring out the big boys and get up to like cefepime, which is a higher generation, or even Zosyn, okay? So that's what we'll talk about when we talk about antibiotics. So lactate will tell you in the first hour whether, what level of sepsis they are. And if it's lactate greater than 4, you're not going to pull any punches. You're going to pretty much start pressors. You might give fluid still. It's ambiguous between 2 and 4. We'll give 30 mLs per kilo, right? And that's where you're giving the your fluid resuscitation. But otherwise, if you can find a source, right, you get rid of the source, right? So you give them a D. You find out what is going on. So you drain whatever could be drained, you debride whatever can be debrided, you pull out any devices that are there, right? And you do any definitive measures, right? We might do like a colon resection for someone with like really, really bad megacolon and colitis and such, right? Or they have a severe obstruction. We have to take out that obstruction, right? So that's the definitive control is the best thing to do. You don't want to just, let's try to optimize them for morning. No, the best thing is to fix it right away. Okay, suppressors, sometimes you need to start them right away if blood pressure starts plummeting, right? It's like blood pressure is like 90 and then it's 60. Oh, let's wait for the fluid bolus to finish. No, they probably just need pressors right now. All right, they're getting sicker in front of your eyes. Okay, so going back to debridement, right? You debride, right? They got stent stone removal, as you mentioned. Hardware needs to be removed. Or they have a permacath in place. We have to take out the permacath, right? If they have a PD cath, you can take out the PD cath. If they have like a wound, necrotizing fasciitis, we got to take that out, debride it and put a wound vac post-op, right? ERCP, if you have a stone that's causing gallbladder sepsis, right? These are all things we can do to control the source. And again, if the source isn't controlled, fluids might not work and pressors might be going up and up and up, right? When do you start pressors? Definitely your MAP starts falling below 65, and especially if the fluid bolus is not working. So how much fluid do you give? Really max about 2 to 3 liters, right? That's really kind of where it's at. Right? It should be 30 mLs per kilo of ideal body weight, but they like to do actual body weight. If you have like a 160 kilo person, that's going to be a lot of fluids you're giving to this guy, right, or girl. So we want to make sure that we're not creating too much fluid overload. And sometimes they can have 2 shocks at once. You can have CHF and you can have someone that has a septic shock as well, right? You can have cardiogenic and septic shock at the same time. So giving 3 to 4 liters for someone with CHF is not great, right? So we got to just make sure that we are not giving too much, because as we know, the fluid we give, the 3 liters we give, 95% of it's going to leak out in the fluid of the vasculature anyways. So that's not going to have a lot of great effort, right? That's going to be about 100 cc's that actually went into the patient, right? So 10% of 1 liter is 100 cc's, 50 cc's is 5%, right? So it's about 150 cc's that actually stayed inside the bloodstream. The vasculature squeezing down will help, with vasopressors will help immensely, a lot better than just giving extra fluids. Okay, and then we have other therapies we can throw at them. High-dose steroids, basically when you're on a second pressor, and that's kind of the time to consider giving steroids. There are some situations where it might be not beneficial, like someone's immunocompromised, and might put them at higher risk, but sometimes risk versus benefits, right? So which one's the better one? But like I mentioned before, that the European guidelines say give steroids early. And with America, they haven't really caught up just yet. They're still saying you got to swell to get well. That's actually completely false, right? That's going to actually make them worse. And we want to make sure that we are, giving steroids early, especially if their pressure requirements are going up and up and up. So usually like Levophed, it's going up to like moderate doses like 10 mics, 15 mics. That's time to initiate steroids, because we know this whole process is too much inflammation. So I'm going to give them anti-inflammation with my anti-inflammatory steroids, my glucocorticoids. And then VT prophylaxis, heparin is actually anti-inflammatory, so it's actually preferred compared to Lovenox, right? It actually promotes the endothelial glycocalyx. And the glycocalyx is what holds your vessels together, right? So that's the, you want your vessels to hold on as much as possible, okay? So volume, when you give volume, you have the ideal medication, yes, the ideal crystalloid you can give. Should you give normal saline? Only if you are metabolic alkalosis. That'd be really the only reason to give it, because it's going to induce an acidosis. And we know patients with lactic acidosis probably should not give another fluid that's going to cause a acidotic state. Okay, and when you give normal saline to like a healthy person, like I think all of us are healthy right now, if you get 1 liter normal saline right now, 75% of it's going to leak into our periphery. All right, so that's the best it can do. Right, so that's why giving fluids is really dubious. Right, in the first 6 to 24 hours, it can have good outcomes, but you definitely don't want to overdo it because it can cause a lot more complications. Okay, so how do you maintain treatment? How do you make sure that they are going to sustain and not going to get worse, right? So, antibiotic stewardship is important, so they don't develop like resistant organisms. But we look for like source control, because if you take out the source, maybe you don't need antibiotics for as long. Maybe just 2 days was necessary, and they got better off pressors, and they're feeling good, right? Improving clinical status, we can say, hey, let's try to de-escalate the antibiotics. Let's go from the strongest stuff like cefepime or meropenem. Let's go down to something a little weaker like ceftriaxone, for instance, right? And then sepsis mimics. So how do you rule that out? That's how procalcitonin is going to really tell you you have a bacterial infection. It's also going to tell you if you need to continue antibiotics. All right, so your procalcitonin is 4, still need antibiotics. Procalcitonin is less than 0.5, absolutely don't need antibiotics, don't need it at all. All right, and there are some caveats there, like UTIs don't really cause a prominent procal, right? So there's certain skin and soft tissue infections are going to release a lot of procalcitonin into the blood. But for the most part, you can look at the clinical picture. They're off pressors. You probably can narrow antibiotics, right? And once you get the cultures back, you can definitely say, hey, that's the antibiotic that is going to work for this patient. And let's take off the other stuff. All right, and then vital signs. Obviously, we're going to make the MAP greater than 65. Heart rate should be good. As we mentioned, a low heart rate can lower your stroke volume and lower your cardiac output, right? And you may need a medication to raise the heart rate, right? On the flip side, if your heart rate's too high, that's going to decrease your cardiac output. So using vasopressors that don't affect the heart rate, which we'll talk about in IV titrations, such as vasopressin and phenylephrine, these two have zero effect on the heart rate. So they have all their effect on vasoconstriction, nothing on heart rate. So ones like AFib RVR in the 160s, my first medication I'm going to reach for is not going to be the Levophed or the epinephrine, which could raise the heart rate. I'm going to reach for something that's not going to do that. Okay, so MAP greater than 65. Again, fluids. That's if your patient was on Levophed and they got off Levophed and then their blood pressure is low, let's give some fluids first. Like, no, it's very rare for a patient in the hospital setting to be fluid overload. Fluid deficit. They're usually fluid overload, right? Unless they have like prominent diarrhea for the last 3 days, yes, they're dehydrated, give volume. But usually, especially like an ICU patient, they are not they don't have a fluid deficit. They don't need more fluids. Giving 500 cc's, 1 liter to these guys is not going to help, right? Just the medications alone we give, like the Zosyn and the Benco and the like zithromycin, and then we give tube feeding. That right there, just in that 1 hour, is about 300 cc's, right? Especially you get Nepro at 65, you got your bolus of Benco at 250, right? And you got your Zosyn at 25 miles an hour. So that itself, you're giving a lot of fluid just to the patient to begin with. And as you know, the fluid is just going to leak out anyways if we do give it. All right, so urine output, that's a good idea to follow to make sure we got good kidney function, right? Greater than 0.3 or definitely greater than 0.5 per kilo is what our goal is. The creatinine is going to tell us if we're getting worse, right? And fluid balance, you're keeping an eye on the I's and O's, and we'll talk about more in renal, but you want by day 3, day 4, you want an even balance. So if they came in and you gave them 3 liters of fluid, by day 3, that 3 liters should be gone, right? They should be back down to where they need to be, and we might have to diurese them if we have to, right? So we might do, so you can support the MAP, right? So you might have to give Lasix to see if we can, support their blood flow, because they might have a damage to the kidneys from the sepsis. So that might be a reason why our urine output's low. Or it could be fluid overload and the heart can't function good. So giving diuretics might assist. Okay. And again, fluids, usually after day 2, day 3, we don't really need to be on many fluids, right? If you're like LR 125 and it's day 4, That's a problem, right? They should probably be on tube feeding at this point. They should probably be getting a lot of extra fluids that will support their blood pressure or support their volume resuscitation, let's say, right? So giving more fluids are not going to be beneficial. Okay, so IV piggybacks provide just about 1.5 liters per day. Enteral nutrition can provide about 2 to 3 liters per day of actual fluid volume. So that's a lot of fluid that's creeping inside the patient. Right, skin perfusion, we mentioned modeling, and lactate. So doing lactate every 2 days or so is a good idea. So usually they do a lactate until it trends down. So lactate's 8, and then now it's 7. Okay, and they let it ride for 5 days. Well, let's maybe every 2 days, let's check to see if it's not going back up. Especially if your patient's not getting better, it's a good idea to check the lactate to ensure it's not getting worse. Right, their sepsis process or their hypoperfusion is not getting worse. Right, so usually you give fluids. Right? Hey, it worked, and then it comes back down anyways, right? And they give fluids again the next day because a different provider, different nurse, they keep trying it, and all this fluid keeps accumulating, and actually can worsen their outcomes, as we'll talk a lot about in renal. All right, so refractory shock is not working. Well, obviously, we mentioned steroids are good options. Steroids are a medication that we can help with all the inflammation that's happening. All right, early interventions with our steroids, and then pressors, we're going to go up. As long as we don't have modeling occurring, really there is no official maximum on pressors. It's just until you get a good blood pressure. That's as much as they can give. All right, we might have to give more antibiotics, meaning more stronger antibiotics. Right, there's this thing called HAT. I've not seen it in practice, but there's a lot of evidence behind it where you do the hydrocortisone steroids, right? But you also give vitamin C and thiamine, right? You do see thiamine for confusion, right? But you don't see a lot of ascorbic acid being utilized. It's more to be like a metabolic resuscitation, right? So help the cells that are being dysfunctioned by all the inflammation, help them function as much, kind of give them as much reboot as possible. As you know, radial art lines can overestimate the BP, so maybe having a target of 70 MAP might be better, especially if they have a history of hypertension, right, because they're used to higher blood pressure. Giving medications together. So you notice that vasopressin alone and Levophed alone don't do great, right? Whereas if you have them together, they're going to be synergistic and work a lot better compared to just being alone. That's why you always see people on Levophed and vasopressin. The vasopressin being a fixed rate, right? So you usually start it when like Levophed's like at 10 mics, they're going to start the vasopressin to help out the Levophed. They're going to be synergistic with each other, right? We'll talk about sedation in IV titrations, but we know sedation can lower blood pressure, but ketamine is great in that it can raise blood pressure a little bit and it can actually control pain. So there's a lot of good things with that. RV dysfunction, we're alert to that, and if they do have true pulmonary hypertension, giving pulmonary vasodilators can help improve their oxygenation. And then different pressors. We have different pressors out there that can be used, little fancy ones like angiotensin 2 and such, but and methylene blue and other fancy things, but just giving, like I said, the norepi and vasopressin together can be additive and synergistic. Right? IV calcium, we know that calcium will vasoconstrict, so we can try it. It's usually a very, very last-ditch effort. And then reduce the MAP target. So how's that going to be beneficial? But sometimes, the pressors themselves could cause complications. Levophed at high doses, for instance, causes tachycardias. Right? Epinephrine at high doses definitely cause tachycardias. So maybe we can reduce the target a little bit, especially if they're a smaller person. Right? They might tolerate a little lower MAP. Okay. So again, we want to make sure that we're fixing the reasons why our pressors might not be working. So they're hypocalcemic, they're hypothyroid, they have an anaphylaxis developing for some reason, like they didn't realize they had a penicillin allergy, and you're still giving like Zosyn, for instance, which is piperacillin. So that might be why our things aren't working that well, right? So they're bleeding acutely, right? Because you can have a GI bleed on top of your septic shock, right? That's what we give, VT prophylaxis for, especially if they're vented. So we got to figure, there's different things that could be brewing behind the scenes that we don't know about. They could be developing a heart failure and cardiogenic shock at the same time they have the septic shock. All right, so we do the source control, we're doing fluid resuscitation. Initially, we're doing antibiotics and vasopressors, right? Insulin is going to help get the sugar under control, so we have our white blood cells can work under 200. Usually our goal is 180 or less, right? Make sure the sedation is not too deep. That's not going to improve outcomes. Make sure we're doing what else? We got lung protective ventilation, because we don't want to get them out of sepsis, but then we caused a ventilator-induced lung injury. So we want to make sure that we are avoiding any kind of secondary injury for someone that has septic shock.